Hi, everybody. It's Kevin and it's Donna, and welcome to an episode of the Med List that I'm really looking forward to. I think lots of families, Donna, when it comes to at least our kind of circle and the communities that I grew up in, we've lost a lot of people of late. A lot of people that I grew up with that were very meaningful, inside of the elementary school and the community members that were rather young, that have passed away. And so sometimes things just happen to families. And if you're listening and your family is related to that, my thoughts and prayers are with each one of you, that you're able to get through a very difficult time. And one thing that presents a very difficult time is Alzheimer's, right? I mean, when we look at any mild cognitive impairment or someone gets that diagnosis, it can be really significant. And so I'm really excited to bring our guest on and us to kind of update folks, both clinicians and patients, on what's going on in that world and that space. And as Donna had mentioned, sometimes there's also drugs that we could pull off, which the med list does like to talk about that. So any other pieces, Donna, for us to be able to intro the audience to prior to pulling Stephanie on board?
Yeah, I do. I do think it's really important that we think about our older adults that we care for, thinking about the working caregivers out there too, but also, thinking about the medicines that can impact cognition and the medicines that we can help, that we can use to help with cognition too.
Oh, can't agree more. Can't agree more. Well, I'm going to bring Stephanie onto the stage. Hi there, Stephanie. How are you?
Good. Hi, Kevin. Hi, Donna. How are you?
So
Good.
good. So good. Yeah, one thing that's so nice is bringing someone back that's a familiar face. Last time, and the diversity that Stephanie has, I think, is so exciting, Donna. That we've got somebody that previously we were talking about all the incredible roles inside of healthcare with Stephanie, and this time we're diving pretty deeply, into a specific disease state. So kudos to Stephanie for her broad skill set, there.
Absolutely. And for some reason, I'm just frozen here, but hopefully you can hear me just fine. Um, but I do want to welcome Stephanie Conway-Allen, Doctor of Pharmacy, and just sharing a little bit where she's the Associate Professor of Pharmacy Practice at Massachusetts College of Pharmacy and Health Sciences. And she also works with the Master of Physician Assistant Studies program at MCPHS. Outside of that, she's a clinical pharmacist at UMass Hahnemann Family Health Center and is an adjunct associate professor in the Department of Family Medicine and Community Health at the UMass Chan Medical School and teaches with Tan Chin Fen Graduate School of Nursing. So you're kind of all over the map in Central Mass, if you ask me, and working with really a diverse interprofessional group, Stephanie. So amazing the work that you're doing. Thank you for what you do. And I'm sure that you might have some inside scoop too on what some of these other entities bring to the world of Alzheimer's and senior care too.
Yeah, I mean, of course, for Alzheimer's disease, well, thank you guys again for having me on. But of course, for Alzheimer's disease, just conversationally, everyone knows someone, right? Everyone has been affected by Alzheimer's disease in one way or another. So just across any health profession, though, we're always wondering what's next, what's in the pipeline. Is there, any progress? Is any progress being made? And so that's sort of where we are now, right? It's 2025. What's going on in Alzheimer's disease therapy? So there's a few new things sort of up and coming, right? We've got medications that have been approved over the last few years that are a little bit more targeted, right? The anti-amyloid therapies have been sort of a big focus of conversation. I'm sure we're going to sort of chat about those later. But one other thing that actually just came out, which kind of applies a little bit more to just general folks in healthcare and the profession of taking care of folks, is some recent information that just came through regarding, lifestyle implications and lifestyle modifications and the impact that actually can have when it comes to Alzheimer's disease. The reason why I'm kind of bringing this up first is because I love everyone's sort of take on what they've heard and thoughts that they might have, of course. But this is also something that's more attainable and practical when we're talking about Alzheimer's. We know there aren't many meds available, and now the newer meds, which we will discuss, of course, but they're a little bit specific and costly and require quite a bit of monitoring and follow up, and they're pretty specific. And so I thought that one thing we could definitely talk about is this some new information regarding sort of lifestyle modifications and the impact that can have on Alzheimer's.
I heard something, Stephanie, this morning. And I know I'm sure Mel Robbins listens to our show, but I started listening to a few of her things because Donna was a big fan, and I thought, well, I'd really like to see what her style is, when it comes to having conversations and really delving kind of deep into some personalized aspects of just life. And she had a neuroscientist on, and that neuroscientist was describing, some things from her childhood that they didn't, in this particular culture, they didn't say "I love you," back and forth. And she said it was really meaningful because later on in life, her dad had Alzheimer's. And she asked during a conversation, Dad, can we say "I love you" at the end of the conversation? And she said it was really neat because the end of the week after she had asked that, he is the one that said "I love you" back to her first. And so some of those lifestyle kind of pieces that are so meaningful to us, that neuroscientist described it saying, like, I knew that was going to happen because it was a very emotionally engaging moment for me to ask that to my father. And so him having the recall to bring that back even during Alzheimer's, was a substantial kind of moment for that family. And so when we're talking about lifestyle interventions, I think that some of those pieces of just being able to add in elements to keep people engaged, right? To look at neural pathways and how people think and process is so important to us. So what are some of those interventions, Stephanie, that you've seen or seen some literature on that you think are really important that folks know about?
Excellent. Yeah. So most recently, some information came out that really was just truly sort of looking at actual interventions, right? So looking at a diet, really focusing on plant-based diets, for example, exercise. So really making sure that the body is moving and a little bit every day, walking especially being at the top of that list, not only just because of the demographic of patients that you're typically dealing with in regards to, having Alzheimer's, right? A little bit older. Let's not necessarily say that they should be, running marathons per se, but they should be walking and they should be doing strength training. We know that strength training is helpful for lots of different conditions physically, and Alzheimer's disease is still it's still physical, right? It's very physical. And so having any sort of movement and including strength training, mild strength training is also important. And then there's also thinking about just general quality of life, right? So, having low stress, so stress management and various interventions there, meditation, yoga, things like that, were found to be very helpful, as well as having sort of social and other support groups, whether it be family, whether it be, through a healthcare community, day programs, or whatever it might be. But having support groups was also found to be very beneficial. In addition to that, and I don't want to jump too far off topic here, but I know this is conversational. So when you were talking specifically about, talking to a neuroscientist, just recently I went to the ASHP's mid-year, and Dr. Sanjay Gupta was our keynote speaker, and he is a neuroscientist. And one of the things that he started to talk about, which really resonated with me, and now it's hitting me as to why, and I think it's because of the fascination with the brain, especially when we think about something like Alzheimer's, and it was talking about how to keep that brain activated and what are the best things to be doing later in life to really get the brain to be doing some new and exciting things, right? Think of your brain as a globe. So if you're thinking of your brain as a globe, right, you only know your area and you know it really well. So it lights up like crazy all the time, right, in that one particular area. But guess what? If you try to all of a sudden do something you have never done before, especially if it has a movement component, so an actual learned as well as a movement component. So even something as simple as doing something specific with your left hand and learning and training yourself how to say sew or stitch or knit with your left hand. So a new skill with movement, and now all of a sudden a new spot of your brain, the new part of that globe is lighting up. And so although I know that that's not quite evidence-based, how I'm throwing that little anecdote at you, but Dr. Sanjay Gupta said it, and I do trust his neuroscientific opinion. But so we've got lifestyle modifications, yes, that now we can look at more concretely: diet, exercise, stress management, support groups, right? But then of course there's just anecdotally my little story here, but again, we know that sort of continuing to learn, changed learning, adjusted learning, and things like that will also help continue to keep that brain fresh and working.
Right. I think too, and I just to add a little bit more, I think one of there's a book, Stay Sharp. That's also Sanjay Gupta book, and it was excellent in regards to really thinking about the thought process of, um, what's important that we do now in order to keep our brain
Mhm.
functioning well and what we might be able to do. So there are all these areas that are important. And I love the one thing that kind of sums it up. I'd heard an interview, and he basically said somebody had asked him, what is the most important thing we can do in order to preserve our minds? And he said, grab a friend, go for a walk, and figure out something new together. Like have
Right.
a conversation about something that is important and try to figure out a solution to the problem. And I was like, that's brilliant. And I was very glad that I do that with my friends regularly.
Yeah.
So I was like, yes, I'm on the right road. But it's so important that we keep our minds where they need to be. What I love about this other thought process before we get into all of the meds and everything else is this lifestyle that we're talking about. One, you can do it, right? And you can call a friend. You can hopefully eat something healthy or pick or choose healthier foods, for example. We had Dr. Robert Graham on about trying to support people with good food, good systems, and that health insurances can actually, some of them pay for healthy food for people. So that was eye-opening for us.
Mhm.
So thinking that there are ways to do this that aren't necessarily expensive. But the one thing about the lifestyle that is necessary in order to improve um, Alzheimer's outcomes, it is pretty intense and it has to be consistent. You got to stick with it.
Mhm.
So that is part of the difficulty, quote unquote, if you will, but it still could be way more enjoyable than taking a medicine
Mhm.
that might not necessarily improve yourself, but might just reduce or slow the progression of
Mhm.
Alzheimer's. And maybe doing some of these things might be more enjoyable than having a transfusion or infusion, excuse me, done. So things to weigh when we're looking at what we might want to be doing in order to improve our minds to reduce the risk of progressive Alzheimer's disease.
Right.
I love the variable kind of component you brought up too, Stephanie, when it comes to just the way we make our minds work. I feel like there's another personal kind of element that comes to that. When it comes to our typical lifestyle, we can really regurgitate one day after the next, right? In lots
Mhm.
of ways, we can zone into just these are the typical processes that we go through every single day. We repeat those processes. We're able to just pull information in, like we can be fed by social media and media in general. But the ability for us to think, to process, and to react. I remember one article I read was really talking about the difference between walking in on a treadmill versus walking on the street, like the things that you encounter, the different balance aspects that you hit, really change the way that you
Oh no.
can see that if you play table tennis or something, you have to be reactive with another individual with that variability that is even higher on kind of the cognitive load standpoint for you to utilize. I bring this up for two reasons. One, because I was telling Stephanie and Donna that I remembered it was somewhere, and so I've got to show it at least sometime in the show. But the other piece is it really connects some of the aspects we're talking about in lifestyle intervention to where we have targeted some of these interventions. So in the Lancet, it went over early life, like all of these are individual reductions in the likelihood an individual will have Alzheimer's. So education. So people that have less education, there's a 5% increase, on the likelihood of Alzheimer's. Hearing loss and high LDL or cholesterol levels, a 7% increase. Depression and traumatic brain injury, a 3% increase. And then going down here to those things that Stephanie was just talking about, social isolation, is one that can be combated with a 5%, increase in the likelihood that someone would have Alzheimer's, or vice versa, 5% reduction in the likelihood they would have Alzheimer's if they didn't experience social isolation. So with some of those things being said, Stephanie, wrap that, kind of weave those pieces in, if you would, to, looking at social isolation. What have you seen when it comes to the literature or with patients, when it comes to combating some of these things and some successful, routes to helping with recognizing hearing loss early, recognizing depression, recognizing social isolation, and how they're interwoven?
Yeah, so it's everything that you just mentioned, especially can really be identified too at the primary care level. So that's also the area where I work essentially, right? So just I really would encourage folks to just be aware that, for example, hearing loss or cholesterol, we don't think of cholesterol as having implications beyond cardiovascular. I mean, we do, right? I do. I'm an academic. That's what I do because I try to look at sort of the big picture when I'm with my students, right? But I guess most pharmacists, or not all pharmacists, would always, make those correlations, right? But we know now that, the body and the brain are connected more than ever. The gut and the brain are connected more than ever. And so I think that just making it. Can you see me?
I can still hear you one
Oh,
sec, Stephanie.
okay. Sorry about that.
All set.
Okay.
Please
Um,
continue.
so I guess I was just sort of saying that, making sure that we identify and highlight some of these items, not necessarily blatantly looking for issues or discrepancies, but just being aware of them, and that they don't, the implications aren't always just on the physical. What I mean by that, again, if you have an older patient that does have elevated cholesterol, we want to make sure that we're not stopping at just taking a look at, their ASCVD risk, right? We want to make sure we're looking beyond that. What does that mean for their cognitive function? Is there anything that, are there other pieces that seem to fit here? Are we talking about, does this person have signs of mild cognitive impairment? And maybe they'd be less likely to put them, in front of you because you're not really asking about them because you're more focused on their cardiovascular health. So just acknowledging that a lot of these things do sort of overlap, and trying to have those early interventions when possible, I think is important. I also think it's important to note that this is, having cognitive issues and slowly for becoming more forgetful can be incredibly impactful in regards to quality of life. Patients understand and they know that this is happening, especially early on. And so, it's probably seems a bit scary, might feel a little bit, you notice if it's getting worse, right? They might feel a little bit daunting and things like that. And so really making sure you have a good rapport with your patients, and a good, asking the right questions, and just acknowledging that there is an overlap, of course, with the physical as well as with the mind. And so making sure we're asking those questions, especially when you've got patients with established cardiovascular disease, with gut issues, if they're, if they have any sort of mental illness, if they, already are suffering from depression and anxiety, and they're starting to become forgetful as well, maybe they're less likely to bring that in front of you because they might be a little bit nervous about what that implies. And so you need to be that trusted and, proactive healthcare professional to initiate that communication. And then from there, then it's just actual screening, right? So if we can acknowledge as much as we can, or identify the risk factors, if we have any in other ways before it turns into let's do an actual cognition screening, then that still might be a good place for you to get a good sense, and to at least make sure that you're hitting on those, or you're getting to do that screening in those patients where you are concerned that there might be risk.
I agree. I mean, I think that the preventative aspects we're talking about to avoid really even the manifestation of mild cognitive impairment is impactful, right? For us to recognize that our folks that are in their 30s, 40s, et cetera, can do things and change their lifestyles to be able to avoid or hopefully reduce the risk, right, of having those things pop up. But one thing you reminded me of, Stephanie, is I remember the Alzheimer's Association put a study out there that it really was looking at a survey of patients of saying, if you had mild cognitive impairment, would you tell your doctor? Would you talk to them at all?
Mm-hmm.
Interestingly, and not surprisingly, 60%, so more than half of the individuals said they wouldn't tell their doctor at all. Like they would hide it, they would bury it, they would make sure that no one found out. That is kind of what is being dealt with. And so I think the call that you make for clinicians, family members, to be able to recognize some of those things and be able to get the help earlier and know that it's not just a diagnosis that is without any possibility of improvement or delay in that kind of symptomology popping up. But it's important to recognize it earlier. The
Mhm.
earlier we get ahead of it, the better that we've seen some of those results, even with lifestyle interventions kind of happen. What have you seen in your practice, I guess, Stephanie, when it comes to some of those folks that are saying this is kind of the first instance they're going, I think there may be something going on? What do you usually walk them through, or what do you see your care team walk them through for an experience of going from, I don't think I have any issues going on with my cognition, to I have something going on? What are my next steps?
Right. So I think that one of the, once it gets to that point where the conversation is being had in the provider's office, like you just said, it'd be really, really great if we are telling our 30 and 40-year-olds to don't forget that although you might feel sharp now, let's stay sharp, and giving those sort of proactive preventative measures right away would certainly be best. But once we get to the point where an individual now is concerned, I think that just to be honest, I think the primary focus at that point is always just learning and hobbies and activities and things like that. And I
Yeah.
think that, most recently sort of realizing, and yes, of course, exercise and diet and the like, but sort of realizing that, there is information coming out to truly support, actual evidence to support that, being more plant-based in your diet. And I am not a plant-based person, so I'm not trying to push that. It is starting to become very clear that it is still, plant-based diets have found to be very, very beneficial, right? The fact that we know that we've got further evidence to support, again, that the physical aspect of walking and the like, right? So we want to be preventative, yes, but once we've got the person now in front of us and they're expressing these concerns, they're going to say, what supplement can I take? They're going to
Yeah.
say, can I start taking ginkgo, or
Yep.
things of that nature? And so hopefully this is when we get to, let's get we've got their attention, and you can encourage them to really get those full body, meaning exercise and meditation, mindfulness, right? Paying, yes, going walking inside is necessary sometimes, but when you walk outside, the mindfulness and, associated with being, present and in the environment and feeling different temperatures and sensations and footing under your feet and the like. And, I guess just bringing that attention to people, that there are so many different ways that they can do it. And it is free to a person, right? To be able to potentially do some of these, even if you have to stay in the confines of your bedroom, there are still ways and apps and things that you can do to sort of just start to get your brain moving, but also just explaining the relationship between the body as well to the patients. Because again,
Well said.
everyone always wants to know what affects them directly, those patient oriented versus disease oriented, right? So if I tell you that this cholesterol medication helps with your cholesterol and exercising will also help with your cholesterol, then you go, okay, great. It's helping with my cholesterol. I don't feel or notice or acknowledge what that means. But if I also tell you that if you do exercise, not only will it help your cholesterol, which will help your heart, you also will help your brain, and you will ultimately begin to notice if you have feel as though you're not struggling as much, right? You're a little bit more clear-headed. Things are pumping a little bit differently. And so, trying to make it clear that exercise and diet can directly affect your brain health, I think would also be helpful.
Huge, huge.
So I just wanted to throw out there that when I was looking at some things, there's 6.7 million people in the United States that have Alzheimer's diagnosed. That's incredible. And so you can only imagine the number that are undiagnosed because people aren't saying anything, right? Especially early on. So, and these newer treatments that are coming out, you really do have to speak up, if you will, in order to get the treatment, if that is what you're hoping for. So I'd love to dive in a little bit into some of the older, newer and then some of the newer treatments and what we're seeing for outcomes for folks and things that we need to be careful of for the individuals. So just want to talk a little bit about the different stages first, and that there's first this mild cognitive impairment, and then we move into mild dementia, and then moderate dementia, and then severe dementia. So those are kind of the places where we have identified, if you will, for various stages. In the older treatments, or the treatments that have been out for 20 plus years, donepezil and memantine, those tend to be more in the mild, moderate, and severe dementia phases where those can be used. But now we're starting to see these newer products that are now being started in the mild cognitive impairment or mild dementia area. So I'd love just to talk about how important it is, if people do want to make a change, that they start, I guess, thinking about the changes of their brain, maybe going for the screenings that are available, and then considering treatment, maybe earlier on than waiting till later. So Stephanie, do you have some words of wisdom on that, or what you've seen, or what you're teaching?
Yeah, I mean, so these newer medications, right? We know that they are pretty complicated. Just in general, they're expensive. They have very specific parameters as to when they should be initiated. They have very intense monitoring that's associated. And again, I can say cost over and over again, right? So, that's what we're sort of thinking about here. So these are only indicated for early to mild stages. Essentially, it's supposed to be if they have mild cognitive impairment. But so how do you diagnose that, right? I mean, yes, you can do the MOCA, right? That's helpful. Early on, it's a little bit more specific. Okay, but in which patients are we looking at truly using these? Are these going to be the patients that have a strong family history? And so are we trying to catch those folks early where we know that they're most likely perhaps going to develop severe Alzheimer's disease? I don't know. Is it strictly based off of access and monetary, implications at that point? I don't know. But in regards to, how these medications would be initiated, I mean, I'd love your thoughts too, right? I mean, it's not even a discussion point, essentially, at my health center. I'll put it that way, because we're not dealing with folks that maybe have the money, the means, that are going to be able to screen. We are instead going to be focusing on those lifestyle modifications and the like, especially with this new information that has some very specifics that came out regarding that lifestyle modification. But, it's not going to be a medication as of right now that I think is rolling out in any great numbers, just because of I don't know, the ambiguous nature of the screening prior, the cost associated with it. So I would actually love your thoughts as well, Donna and Kevin.
Yeah, I've got to pitch it to you this way, Donna. With what Stephanie kind of introduced there, when it comes to someone just recognizing they may have some kind of issue, maybe it's subjective cognitive impairment, even at this kind of state, that jump that Stephanie mentioned is, now I need a supplement. Like, I need something to keep me together. Like, what is the missing ingredient that I can plug in there, and now I'm good to go? I'm not saying that they don't also want to add on lifestyle changes, but oftentimes the first kind of go-to, surprise, surprise, in America, is, what pill can I take to be able to avoid anything else? At least in my experience and research over the years, Donna, I have not seen extremely high quality evidence that a particular supplement has been exceedingly valuable. I've seen some anecdotal studies that have come up there, or some mid-level evidence for one or another. But what are your thoughts there on that kind of first stage of someone going, is there a supplement that could be right for me?
Yeah. So I agree with you, Kevin, that the studies aren't out there to say, yes, this is what you should be using. And so, like the ginseng and things such as that, they're not going to make you smarter. They're not going to clear things out. Anything that any of these meds are going to do is slow progression. There's nothing that is improving. It's all slowing progression. So with that said, that this is where things get a little funny to me, where you're spending money and you're taking a product that might help you down the road, but it's really hard to know whether or not the product is working, because there's no true way to look to see if you're progressing less than if you weren't taking the medicine yourself. So that I think is a little bit difficult. So some of the things I'm talking about is, so say some of the supplements, there might be Prevagen or ginseng, something like that,
Right.
where ginkgo, those are products that might slow progression, but there's no measurement there. There's really no true measurement in order to be able to see this improvement. When we're looking at the older meds that have come out for Alzheimer's, things like the donepezil and memantine, again, slow progression. They're not improving people, so people start taking them. They're not going to be necessarily sharper or clearer minded. They're just going to slow the progression. So, are they staying at a baseline? Even the newer products, so products that are available now, and there's one that was on the market that's already off of the market, and that's aducanumab. So that was very short-lived, but again, reducing progression, but had so many side effects to it and really didn't have good, clear clinical outcomes for the patient at all. It actually seemed to be causing more harm than benefit. So that has left the market already and not available. But then there's lecanemab, and that again slows progression of decline. It does reduce the amyloid burden that they are able to see in some MRIs, but again, really high risk side effects, which I think we're going to get into in just a few minutes. But then the other one, donanemab, again, slowed progression, decreased amyloid plaques, and it also causes a reduction in tau. So there's some changes there, but again, we have to be super careful, and there's a lot of evaluation and continued expense with having to get MRIs regularly in order to see that these aren't causing more harm than benefit.
Yeah, I remember so many conversations, Stephanie and Donna. You can either nod your heads or not if you've had these same ones. But when it comes to supplement utilization, for the most part, if it is something that is not going to be, here's a Scrabble word for everybody. If the pharmacoeconomic burden, meaning that the drug costs, right, aren't too much for the individual patient to bear, and they have real belief in that going to be something that's going to be meaningful for them, and there is not a significant side effect profile or something else, then hey, great. Like there's something to placebo effect, to me. But when it comes to data, what I've kind of seen over the years is a high quality multivitamin, as long as it fits with the rest of your regimen, is probably one of our best bets when it comes to any supplementation, kind of period. The other piece though, that's kind of interesting, even, looking at the supplements that I know that all three of us would mention is, what are the drugs they're already on? Are the medications they're already on causing, some of those symptoms and those issues that are cropping up? Oftentimes, I'm sure folks that have listened to the show, we're big fans of anticholinergics. Medications that are causing, issues with cognition, are ones that can be evaluated. And I think are just as important as Donna and Stephanie are pointing out. We're talking about reducing decline. We're not talking about improvement. We're talking about reducing decline. Looking and evaluating the current regimen for individuals, I feel, is just as important, if not more important, than evaluating the other therapies that are currently on the market. Any thoughts? I mean, I'm excited if you guys disagree either way.
So this is definitely one thing that I focus on when I talk about this with my students. It's also those unassuming medications that might contribute to the appearance of confusion or memory loss and the like, right? So it's, of course, the anticholinergics, sure. Of course, it's opioids. Of course, it's benzos. Of course, it's any sort of anxiolytics or anything that's, sedating and the like. But we're at the point now, though, I will say, where I feel like it's all I'm doing, Donna, is thinking of you and the need to deprescribe every med list that I look at, especially because the list of, those anticholinergic or again, those that might cause or contribute to confusion and the like, blood pressure lowering medications. We forget that those can contribute to patients feeling confused, they get lightheaded, they can't quite, recall, they feel winded, and that hits different folks differently. So I definitely agree that first review is so very important, to not just figure we should throw a med on board, but let's see if there's anything that could be causing it. But in regards to the supplements, another thing just to note is that, I essentially talk about these supplements. The reason why they work, yes, they may slow the progression ever so slightly. Yes, maybe they have antioxidant effects. Okay. Right. But usually they're just thinning the blood. So they're sort of just serving as helping with that vascular perfusion, right? Just like aspirin. So years ago, we used to just throw on 81 milligrams of aspirin when we threw the donepezil on board. As long as there wasn't a blatant contraindication, we would throw that on board because it would help potentially, right, with vascular dementia, with getting that oxygenation to the brain, etc. That's what I think of when I think of ginkgo, right? There's a reason why ginkgo and ginseng and all of those need to be immediately stopped if you're going to go in for surgery. We call it the G drugs. You got to stop those G drugs. They usually contribute to bleeding. And so, although some of those meds might even be okay, again, thinking about our clientele, our patients, right? Our patient body, they are not likely the patients that should be on meds that could potentially contribute to bleeding because they're most likely on other products as well. And the other thing too, vitamin E, I get asked vitamin E, it comes up as something that should be utilized, but we know that in doses that it was found to potentially be helpful is far above the dose where, mortality is then a risk. And so without scaring folks, I do think it is important to identify that as well. And so kind of really circling back to when we were talking about identifying folks earlier to start doing different, lifestyle interventions and watching their cholesterol and exercising, not only for their heart, but also for their brain. Those are the folks too that you have to be cautious of that are going to want to start taking supplements. And although it could potentially be okay, right? We don't want to start taking something when instead getting some exercise in and drinking some more water might be just all that you actually need at that point. But it really would just be flexing that brain as a muscle as opposed to throwing those things on board too early.
Yeah. So talking about some of the newer meds too, and I'd mentioned, some of the side effects. So lecanemab and donanemab, there are these things that are called ARIAs that we have to be aware of. And I think it's important that clinicians and patients alike know about it. And what I've seen a lot of write-ups on and various listservs is that it's really important that in emergency departments that they're aware that they're able to read if somebody is on these medications and what the brain imaging might be, especially if someone has fallen, that it can get pretty interesting, if you will, if they're looking at these amyloid related imaging abnormalities. So they have to be super careful of various types. And there's edema, or effusion, or there's a hemorrhage that can occur. And so I know that we talked about, this early detection for Alzheimer's, but we also have to be careful of these potential side effects. And some of the people who might be looking at starting these medicines earlier, those that have that APOE4 gene, which is an increased risk of Alzheimer's. So if they do carry that gene, then 43% of folks can have these ARIA side effects on these newer meds. And then if they're non-APOE4, then 20% of folks are at risk for having these particular types of side effects. And then that's going to determine whether or not treatment can be continued or not, as to whether or not this is mild, moderate, or severe ARIA that someone is experiencing. So I think there's promise for these meds, perhaps for people, but unfortunately, I also think that there's this potential that people also need to know that they might have to stop it if they are indeed having these issues and having these brain changes. So any words of wisdom on that, Stephanie?
So I actually just decided to take a look as well at just even the cost again. And I know that it doesn't always have to go to pharmacoeconomics, but it kind of does when we're talking about a medication. some of these meds, right? So not only does we first need to acknowledge that mild cognitive impairment may be present, or maybe we're worried that it's at risk. So we identify it. Now we do some screening. Okay, if we identify mild cognitive impairment may exist through a discussion, now we need to do. Are we going to get some biomarkers? Are we going to do genetic testing? I'm just looking up. So getting genetic testing under a clinical setting is, $200 to $1,000. Insurance may or may not cover it, right? So that's right there. So now you're getting some testing done first. You're going to have to get some imaging done first, right? To even see if you're, if you qualify. Are you in a place of mild cognitive impairment or mild dementia at that point, right? And then you're talking about incredible amounts of money. And then again, as you mentioned, Donna, you may not even be able to continue with the medication, because if you do end up with these abnormalities, it means that you may have edema, brain swelling, you may have hemorrhage, right? And we don't know what that actually looks like, what that means for our patients yet, because the number of patients where we actually are seeing that have used this medication is so small. And then the actual, like you said, 20% of folks that have a particular gene, right, are increased likelihood of ARIA. But you're already at an increased risk of ARIA on its own, right? And we know that this obviously can be dangerous. So it just seems like a great deal of money for unknown outcomes. But one thing it does show us is that they're making progress of these targeted therapies, of trying to figure things out. I just am personally have some reservations about whether or not it should be in the community at this stage while they're still figuring out all of this. And so while it may be successful, I know that the prospect, I think that years from now, we're going to hopefully have some wonderful stories about these anti-beta amyloid products. And again, you mentioned now they're starting to target tau. Wonderful, one step at a time. But they, at this point, those lifestyle modifications and early intervention and really taking care of the body is at least the best place for everyone to start. And then we know that there are other options, but where they really fit in therapy is still, it's hard to say.
Well said. I think the ARIA topic, it may feel for folks that we're getting into some nitty gritty details on that, right? I mean, we're looking at some image abnormalities that are coming up as a side effect. We're talking about genetic testing. Stephanie broke down that we're talking about at least one genetic test, right, that ends up going in there. And it's not one, image study. We're looking at, you do an initial image study, and then you have 3 other subsequent images that have to be taken, plus more after that if you continue with the therapy. So the costs that are totally unrelated to the drug are pretty substantial, the healthcare system and the amount of time being spent. And I feel like when it comes to our investing in, what we're doing, and we talked the other week with, and we've done it several times, Donna, we've talked to individuals that are looking at using interventions that are very low cost interventions, sometimes really high touch even. If we're talking about a drug, let alone all the other things that are costing $26,000 a year, I can think of a lot of great interventions that we could give our patients when it comes to how can you eat better? How can you move more? How can you interact with other individuals for a $26,000 investment that would make a lot more sense, right? Overall for us when it comes to an ROI from the healthcare system. So saying all of that and kind of looking at those treatments that are kind of burgeoning, the new ones. What about the ones that are already in play, Donna and Stephanie, when it comes to the donepezils, the memantines that are currently out there? Let's talk about not only, starting them or considering those ones that are much cheaper, overall, but they're not without problems.
Yeah, for sure. So for one in particular, Kevin, I always think about donepezil, and when I see that there's some cardiovascular issues or syncope going on, someone's on donepezil, and I was like, whoa, can we stop the donepezil, or can we reduce the donepezil? Because that's an issue. If we're having cardiovascular changes and syncope, it's probably a good chance. But what we've seen, unfortunately, happen in talking about expense of continuing drugs is we'll see people have pacemakers placed and yet they're on donepezil. But it could really be that if the donepezil was taken off, which is maybe having a questionable benefit, or maybe it's worked to a certain point, and now at this point, the patient isn't really doing any better. They're actually doing worse. And have you exhausted the time of donepezil being beneficial, and now it's harm that's ensuing versus benefit. So I think that's another balance. We talk about this all the time with meds. You start a med, maybe it's going to help you for a little bit, but eventually you could have that harm happen. So if that is the case, if you're now having more harm from a drug, it's probably well worth it to stop that drug and to maybe change it. So maybe memantine is the sole drug that you need to take instead, or maybe it's come to a time when the medicine is not appropriate for you at all.
And I just have a comment for that too, Donna. And this is where I think it gets a little bit tricky. It's because there are so few options. I certainly understand why you might have a patient or your family's reluctancy to take something off, right? Because, when we talk about this in class, we talk about the hope is, right, the acetylcholinesterase inhibitor is successful or considered to be successful or effective if the patient is declining at a rate that is slower than what they would be declining at if they were not on the medication. But like you said, where is that, right? I mean, at what point is that actually happening? And is the amount with which they're not declining, right? Is that difference worth the amount that they're now struggling because they have cardiovascular issues or other drug interactions that might be of concern? And so we're trying to keep the donepezil on because we're afraid of how quickly the patient may progress without it. But at the same time, if we're thinking also of quality of life and how much the donepezil is most likely actually helping, right? But that's a hard conversation to have with folks to essentially say we're going to stop their Alzheimer's treatment, but the reason why is because it is no longer being beneficial, but more so it's now causing those issues, and that's a difficult conversation when it's the only option that folks have.
Well said. Yeah, I think there's that balance that it's easy enough for us to sit back and not have a family member on, one of these medications and feeling like they were benefiting from it overall and saying that, the side effects are overburdening, the individual, let's pull it off. Another story when you're the individual's son, daughter, family member, to make this and then feel like, am I giving up on that individual, right? So that's a really difficult position, that folks are in to be able to work through. And I think that relationship kind of development that has to happen between clinicians and family members as well, especially in this setting, is pivotal there. You can't have those tough conversations without that already being in the background. Otherwise, you're a stranger that's asking for them to do something that they are very uncomfortable doing, overall. Along those exact same lines, I'm really curious from your guys' perspective. Let's say we pull someone off of Namenda, we pull someone off of Aricept, and now what? Right? These individuals are saying, now I don't have these cardiac problems. I don't have these stool and or diarrhea related issues. All these other problems that were happening to my patient and now gone, right? Or they're better, but the cognitive impairment and or decline is still happening. Where do we go next with those folks in kind of helping them in this modern kind of treatment phase of Alzheimer's?
That's the $1 million question, Kevin. And it's unfortunate because there isn't. I don't think that there is anything. I've lived through it with family members and having to do that whole course, and it's difficult at best. And I think this is when not where you're shifting gears and you're trying to do comfort and you're trying to use other type of non-pharm practices. So what was helpful was prayer therapy. Others, we had music therapists on before. I think those are the therapies and the comfort that come in is keeping somebody comfortable and relaxed, and wherever they're at in their mind is where they need to be. So if they are loving the music from whatever era that they're kind of in right now, when they were first married or before they were married or whatever, play that music, and it might be very comforting for them to do that. Or like keeping that schedule and system going and keeping them comfortable and understanding that people aren't going to be able to say, oh, I have pain. And maybe if they're wincing or just fidgeting or agitated, maybe some acetaminophen is what they need in order to get that edge off. So trying to, or maybe a heating pad or something, like just something very wonderful and soothing for them. Weighted blankets can be super helpful too. Being in a very comfy chair that surrounds them can be very comforting, almost like a hug for them.
Mhm.
So there's a lot of different things and I think that's when you have to look at your specialists and say, what do we do now? Look at your OTs and get that guidance.
And I think, Donna, that just mentioning even those other professionals, right? The interdisciplinary approach or multidisciplinary approach is huge here. And the other thing it makes me think of is even sort of before, if we get to the point where we're not sure that the meds are the oral meds are, we don't need to keep them on board. They may not be as beneficial anymore, but really having the conversation with either the patient or their caregivers, depending on, which stage or where we are, but with what is your primary concern? What issues do you want us to address? Because if you have a patient that, we feel like we want to treat one, or we think that something is bothering them, when in reality, when you talk to them, they say, no, I actually, it's not, I actually sleep fine, right? Instead, it's more of my mother's seasonal allergies have really been out of whack, and that's what they really need treatment for. But maybe because of drug interactions, we weren't using something, or maybe because we were trying to avoid, again, anticholinergic symptoms, so we weren't using any histamine. But what I guess my point is that when you get to a point where it's quality of life and really trying to maintain quality of life, that's when you have that conversation of what do you want us to make sure that we are addressing? Is it sleep? Is it perhaps, the pain in their hands, and so they're not able to do something that they enjoy, like knitting or something, some sort of a hobby and the like. So, not only making sure that we come up with different ways to physically take care of and treat and support our loved ones, but then also asking the caretakers and the patient, what do you want us to treat or focus on for you, especially because you can only do so much with those acetylcholinesterase inhibitors, or with your memantine, right? That can only stay on for so long. If they're going to be off, then, don't forget that we still want to make sure that the patient's Alzheimer's is still being treated, and that we're still taking care of the patient, regardless of whether or not we're treating that particular disease state by indication.
I feel like Alzheimer's is really unique in this way that when we talk about palliative care, oftentimes when we're thinking of hospice, especially, we're looking at 6 months, right? 6 months of kind of a duration for typical individuals to go through, just trying to be comfortable, and the family members trying to work through that for that short period of time. Alzheimer's is unique that can be much, much longer, for family members to work through, and also very unique for both family members and care providers, that you have to make the pivot from, are you treating the patient any longer, or are you treating the family? And that is a switch that ends up happening. And I think if I have any kind of anecdotes that I think I'd love for people to know about here, Stephanie and Donna, are when that happens, when a family member is diagnosed, right, and you're starting to notice those things, having those conversations between family and that loved one about, what do I do at this stage, mom, dad, aunt, uncle, whatever the case is so empowering, for those individuals to have that in their back pocket, have a plan put down that was blessed, by that loved one that's going through the disease state. And the other one is the utilization of care groups or caregiver groups in general. Like, there's support, that's out there from other individuals going through it. And I think it's just as important to treat those family members as it is to treat the patient, during that stage of Alzheimer's as it's progressed there.
Absolutely. Awesome. Well, thank you, Stephanie. Thank you for joining us for this conversation and to go through some of these medicines. I think we've kind of shown all sides of it, and it really is an individual basis, as always, in thinking about what's most important for the patient and what matters to them, and what they're able to maintain for, are they able to stay mobile and social and all these things that they want to try to do for as long as they can. So really, really important conversations, important follow-up, important to be monitored for any of these medicines that you're taking. And if they are beneficial, wonderful, but know that there can be a time when any of these medications could actually um, become more harmful for the patient than beneficial.
Right. Yep,
Yeah, so
absolutely.
true. Any parting words for everybody, Stephanie, on kind of the big takeaways?
I guess lifestyle modifications and improvements work across the board. So again, we know that, maintaining physical health, cardiovascular health, is imperative. We know that, of course, but just seeing and having more information and evidence come out to support how much taking care of the body can help take care of the brain, I think is a super important thing. And do what Sanjay Gupta said, right? Try to learn something new and try to learn it with some kind of a movement component, or like you said, Donna, grab a friend and go for a walk and have a conversation, right? So just really trying to make sure that that all folks continue to flex that brain muscle, right? And continue to do that early on, and hopefully that will will decrease the likelihood of that brain getting tired. So try to strengthen it while you can.
For
Love it.
sure.
Yeah, that's perfect. I think the quality food, quality relationships, quality movement, are all kind of elements of that, and learn something every day is beautiful. Lifestyle, it just matters, and drugs can't beat it. And so thank you guys so much for joining us here on the MedList. Thank you, Stephanie, for being here. Any questions, anything else? We are on YouTube, LinkedIn, and Facebook, and we'll see you guys next time. Have a great night.
Thanks.
Thanks.
Take care.